Welcome to Knovva Academy. My name is Alex Crosser and I'm head of online learning. We're very excited to present the Pandemics and Public Health Initiative designed to help teens around the world be better informed about one of the most impactful events of the modern era. The COVID-19 pandemic is an unprecedented challenge to our modern systems of healthcare and to the heroes on the front lines working to save lives. How does treating this pandemic differ from the way they've treated patients in the past? What's it like to be on the front lines? What challenges are they facing and how are they coping? We're very fortunate today to be joined by Dr. Bella Mehta from the Hospital for Special Surgery in New York City and a faculty member at the Weill-Cornell Medical School who can help us better understand the situation on the ground. Dr. Mehta, thank you so much for taking the time to speak with us today.
No problem. Pleasure's mine.
Great. So in a few words, could you introduce yourself and describe a bit of your background as it relates to our conversation today?
So I grew up in India. I did medical school in India, and I was an intern at the time of the H1N1 flu. And I was working in some of the most poor neighborhoods in Mumbai. That's where I'm from. And I had seen an epidemic / pandemic at that point. Then I came to the US to train. I trained here as an internal medicine physician, and then I went ahead and trained as a rheumatology physician. Also, while I was studying all of this, I also did a master's in public health.
So Dr. Mehta, you're an expert in rheumatology, but COVID-19 is a respiratory disease dominantly. So I was wondering if you could talk a little bit about what rheumatology is so we know where you're coming from, and then a little bit of how you got involved in treating COVID patients as well.
So I think at this point, every physician in some form or the other is getting involved with treating COVID patients. Whether it's just COVID wards or in other forms of practice that you already have been doing. So a rheumatology physician is typically who treats things like rheumatoid arthritis, lupus. These are diseases where your body's immune system attacks your own organs or joints. So as a rheumatologist, basically, you have to try to stop the body doing autoimmune things, which is attacking your own cells. So I have patients who already have rheumatoid arthritis or lupus, and now they get COVID. So now all of the treatment responses are different because you cannot do things that you typically did, and so you need to readjust. Like all of us are readjusting in our lives, in our practices. Even medical professions are changing treatments, not only for COVID, but even for existing diseases that we already knew how to treat. We need to change our practices very dynamically in a very personalized way.
Can you talk a little bit more about what those changes look like?
So, for example, if a rheumatoid arthritis or a lupus patient gets COVID, it is not typical COVID, and the implications for that patient are different, and the medicines that need to be put in or put out are also going to be different when a person with a pre-existing condition gets a disease like this.
So could you say a little bit more about what is happening with your patients who may have needed procedures that are being put off, or I don't know how much you can speak to the bigger picture, but I know a lot of hospitals are being sort of turned into de facto COVID wards right now.
Typically, some of these hospitals, we have elective surgeries, we have patients who are coming in for like routine appointments. At this point, there is no routine appointment happening. There is no elective surgery or procedure happening. It's unfortunate, but some patients have to just, push it a little bit. In a typical hospital, there's, there's outpatient clinics, there's inpatient wards, and then there's ICUs. And each of them is different levels of service, right? For an outpatient, usually people are not as sick. They come in, you treat them, they go back home. for a hospital ward, the typical hospital ward that they talk about, patients are sick, but not sick enough that they need like continuous intensive monitoring. Whereas the third section is where, there's where they go into the ICU and there's a lot of care that they require. Maybe they require something called mechanical ventilation, where there is machines that help you breathe. So at this point, unfortunately, the outpatient practices are almost shut down, except for like minimal required for emergencies or urgent things only. The wards have, usually the patients that we think of in the wards are not that sick, but the wards have become ICUs in a sense. So the whole hospital, which used to have these three buckets, has turned into one big ICU. And I would say most of New York hospitals are like that. At this point, we've never required so many beds or so many units as it is with COVID right now.
That must be quite scary to see the normal way of things so upset. So because a lot of patients are having to put off elective procedures or regular checkups, do you have any longer-term concerns about what the consequences of putting off these procedures might be?
I think that's something that all of us are really worried about. But again, we don't have an option right now. I think for now, it's just like, let's take care of the acute issues. Let's see what subacute issues you can manage remotely. And let's hope that people with the chronic issues, with some wait time here and there, we can find the best solution for them. So for example, there are patients with rheumatoid arthritis who need labs. So we're trying to set up testing centers for our patients remotely instead of them coming into the hospital. So again, like, I think all industries and every person in their own house is trying to find a small solution to a problem. All of us are trying. Again, I think there would be some patients who would suffer because of this. And I think the vulnerable group, the low socioeconomic status, the minorities, they would be suffering the most. And I think we as society should work towards taking care of them specifically.
So I know you have an expertise in disparities in medical outcomes. So I was wondering if you could talk a little bit about the intersection between that and what you're seeing with COVID patients.
As we've all read in the media, that COVID affects the lungs, and it's a respiratory virus essentially transmitted between person to person. And we know that pre-existing conditions like having heart problems make you more susceptible to COVID and more susceptible to having adverse outcomes. So we know that certain populations like African Americans in the US have a higher predisposition for heart disease to begin with. So now when they develop COVID, their probability is increased because now they are affected by both the things, one which was pre-existing and now which is added on with COVID. So I guess with COVID, it also flares up in some sense the already pre-existing disparities in the population. Socioeconomics is one measure, but it is tangentially related to the number of blue-collar jobs, to what people have to, I guess it's related to, again, the number of blue-collar jobs and how some people are just essential and they have to go to work, whereas some people have the privilege to stay at home. So now firstly, their probability of getting COVID is higher because of multitude of reasons, socioeconomics, essential workers, a lot of misinformation. socioeconomics is not the only thing that is driving disparities, right? In the United States or all throughout the world. I think it's a lot of other things like language, culture, minority, all of this sort of plays a role, because there is a lot of social media and WhatsApp going around that COVID is not real, or it doesn't affect our community, and things like that. And these are the sort of messages drive entire communities into a risk population. So with all of this, some of these minorities are going to get much more susceptibility to it. Once they actually have COVID, their pre-existing conditions make it worse for them. So overall, the whole dynamic, which was probably slightly bad, now becomes really bad for a lot of the minorities. At this point, I mean, all of us have been reading the media, and you see reports from the Washington Post or the New York Times talking about how the death rates are higher in African Americans compared to whites, even with the same sort of locations, same sort of resources available. So we are actually, as a research team, digging into this, even though typically we were not COVID researchers, but COVID didn't exist before this. So we are all sort of interested in decreasing the disparities and seeing how we can achieve some equity by working towards this and studying how these disparities can be actioned upon from a health policy level. Because there is disparities. Disparities existed before COVID, but now it's exacerbated. It's just blown up in some sense with COVID. And I think it's important for us as physicians, as researchers, and as society to recognize it and see if you can do something to correct it.
So you mentioned that you and your peers are all becoming researchers in COVID-19. And so as you think about possible policy outcomes that'll come as a result, I was hoping, A, you could mention what some of those possible policy outcomes might look like. And then B, where do you think it's most needed for public health experts to have a seat at the table in order to have these policy discussions?
Our job, in some sense, is to generate the data and show the public, the politicians, about what is going on, and give them a set of strategies that will work or may work, right? So for things like where I think some of our research is headed to is, now we know that certain populations or certain communities are at a higher risk of developing COVID and having adverse outcomes to COVID. So I think in some sense, like everybody says, we should have planned better, but since we are at this point, we can plan ahead for the return to the new normal, right? So if we are going to open up at some point, which we will, we need to target these communities and then treat, test, and trace, right, these patients. So we need to target these communities so that we can find the patients who are symptomatic, test them early on, and then isolate them. Because again, the COVID-19 doesn't see who you are. It affects everybody, rich, poor, minorities, non-minorities, everybody. So some of the research that we are headed to would help policymakers into testing certain communities or certain groups of patients when we return to the new normal. And God forbid there's another pandemic, we would have targeted responses at the get-go, which we missed the boat this time.
So if you could go back, or I guess going forward, what questions are you researching right now to find answers to help us prepare for the next pandemic?
I think the main questions would be that, which are the populations at risk? How can you make sure that these populations are given the right information and the right information is spreading? Also, getting testing available to these populations early on. What happened in something like Queens, right, in New York, again, a very high risk population, low SES, low socioeconomic population with highly immigrant density. Again, a lot of them do not speak English very fluently in a country where English is the first language. So again, like there was a lot of misinformation. So there were these clusters, which what you call in epidemiology, where there's high density of disease and then they spread it across too.
So I want to go back to the idea of telehealth for a minute. So I was hoping you could talk about your experiences transitioning from an in-person practice to a telehealth practice. What are some of the benefits and what are some of the challenges? And then I would love to go into how access to telehealth may play into some of the disparities you've been discussing.
So, I'm a rheumatologist, so we usually like to examine patients and touch them and see how their joints are doing and see if there's anything going on with their heart and lung. And so telehealth definitely has disrupted the typical, but I guess nobody is living in the typical anymore. I miss the examination part because I think it gives me a lot more data points, but I do think that it at least provides some sort of care that I can give to patients, because there is some things that you would obviously know just by talking and seeing the patient too, even if it's over the camera. In some sense, telehealth was pushed for a long time, but a lot of doctors did not want to adapt completely. Especially, there are physicians who are not very tech savvy, as they call it. But now all of us are sort of forced into telehealth. There are obviously the advantages. There's some visits where patients can just talk to you from home and then they don't have to travel all the way and come to you. Access definitely increases in that sense. But telehealth also exacerbates the same disparities that we're talking about, because these are the same people who do not have access to broadband internet, do not have access to a webcam, or maybe don't have the expertise to, or the technological ability to go online and figure it all out. A lot of my older patients, they do find it difficult to maneuver through like the application and sign up for the application and then go online and do the appointment online. They were much more used to calling us and like making an appointment and just coming in. So telehealth in some ways increases access to a lot of people, but it differentially decreases access to people who probably would have had some sort of access with physicians or the medical community.
Interesting. Thank you. Thank you for touching on that. So I'm really curious then, since a lot of you and a lot of your peers are not experts in respiratory diseases, what are some of the biggest challenges you and your peers are personally facing as you try and shift your practices and shift your areas of expertise?
A lot of us are, internal medicine trained before we were specialists, or we were doctors before we went into a particular specialty. But with COVID, actually, I find it very refreshing and collegial that a lot of surgeons or rheumatologists or psychiatrists or pediatricians who've not really taken care of sick infectious disease patients for a long time since they graduated medical school have now stepped up and volunteered and said that, hey, I was trained like many years ago to do this. I don't have practice as much, but I would love to help. And, you learn quick. And still, there's a learning curve for everybody, but it's been an interesting experience.
So as you're all taking on these new challenges, I'm sort of reminded of back when you could fly on airplanes and they told you to put your own oxygen mask on before you put the mask on a child or someone you're traveling with. And so, you're putting yourselves and your lives on the line to take care of COVID patients. What are you and your peers doing to help maintain your own physical health, but more interested in your mental and emotional health.
Yeah, so that has been a challenge, right? There's PPEs and whatnot now available in all the hospitals, and they make sure that you know how to do it, and like they keep reiterating it so you're physically protected as best as you can. But mentally, I'd say that it's been tough. Again, I'm a rheumatologist. I haven't particularly been in the COVID wards seeing so much death myself, but I have colleagues that I trained with. I have colleagues that went to medical school with. They are in the ICUs day in and day out, working what usually are 12-hour shifts, but now have turned into um, 16 or 18-hour shifts. You don't want to leave your patients sick and dying, and the next person coming in is also has a lot on the plate. So these shifts are extended. So physically also it's burdensome, but more so seeing so much death or so much suffering, and not having family members with the patients itself is taking a toll on a lot of professionals, I would say. I mean, the nurses who are like working so tirelessly, none of these ICUs can work without them, right? They go into these rooms 15 times a day, looking at the vents and looking at the drips and looking at the medications, making sure the patient is okay. I think in this sort of adversity, one thing that has been a silver lining is that the medical community, nurses, everybody has come together so close. Um, for the smallest of things, everybody is there to help each other out. And like there are physician groups or there are colleagues that I haven't been that much in touch with. Now we're texting every day to check up on each other and like talk about patients or do something so that we're all engaged and not somewhere isolated with the stress of seeing so much illness and death.
Hmm. One of the most moving things that I've seen of late is the 7 o'clock thanks that New Yorkers give to all you medical professionals. Just the sound of so many separate people coming together to show their support and gratitude for what you and your peers are doing, I found really powerful. So I was wondering how that makes you feel, and how can people who are not directly involved in the medical community thank and support you and your peers going forward?
I mean, it's nice that there are people who are recognizing not only physicians, but the entire healthcare worker teams. Um, something early on, which even I didn't realize being in a hospital for like so long, is that we needed to change all the vents in the hospitals to make it negative pressure rooms. So environmental services and all these workers literally within 1 week of the epidemic started changing basically the hospital infrastructure completely. So there's so many people who are working on this. It's not just physicians or nurses. And for when there was a PPE crisis, there were all these people who basically stockpiled for the hospital. They stepped up. So again, these are people that even me being in the hospital for so long didn't know them directly. And now I see how much of a difference they make in the regular functioning of the hospital. So anybody who's remotely involved with the hospital has really stepped up. It's nice that the public appreciates everybody. And I think the way to help out, I think very importantly for the public is to follow the rules, follow the guidelines. I know it's frustrating to not have your normal life, but if you see on the other side, the risk-benefit ratio is tremendous. And the risk is probably not going to X thing or Y thing, or but whereas the benefit is that you're going to end up saving lives, a lot of lives, and a lot of suffering just by staying put. So I think from a public health perspective, I think a lot of people are suddenly very much aware of what is public health, how it's important. And I think we should keep the momentum going in terms of public health, because nobody knew how diseases are transmitted. A lot of people have read up a lot about COVID in the past few weeks, I would say, much more than they've read up on any other topic with so much interest. So I think it for teenagers, I would say, this is an avenue to explore for their careers too, because, you know, I don't think doctors can make as much of a difference in COVID as much as public health officials can, or as policymakers can at this point. So these are sort of important careers, which when I was growing up, I was not exposed to. So for me, I did medicine, I did residency, I did fellowship, where I did advanced training in rheumatology. And when I was doing that, I was like, I think I should also study public health. And that's when I did my master's in public health. But the realization came very late. And I'm very happy that I am a physician who has a public health perspective. So it gives you sort of a vision from both sides. But I think we need more public health professionals too.
So you mentioned PPEs, personal protective equipment. And we know how important that is at keeping people on the front lines safe. So that brings me to a question we actually have submitted by one of our students.
Hello, I'm Yusuf from Cairo, Egypt. Many people in Egypt have been hoarding surgical masks and gloves, leaving healthcare workers in a vulnerable position. Many experts have come out to say that surgical masks and gloves are not proven to decrease the risk of infection in the general population. However, people are still buying them, quoting some doctors who claim that they're effective. According to your expertise, does wearing surgical masks and gloves decrease the risk of infection in the general population? Or should we instead be focused on advice like washing our hands regularly and not touching our face?
So I think that's a very good question and a very pertinent question. I think gloves has no benefit of protecting anybody, because once you touch a glove and then you touch something else, that's just besides the point of prevention. I think about surgical masks, the guidelines have changed over the pandemic, how it's evolved. I don't think surgical masks absolutely prevent transmission from one person to the other. The CDC does recommend people to at least wear something. It could be a scarf, it could be a handkerchief, so that when somebody sneezes, at least the droplets don't go too far. And that way, with social distancing and wearing some sort of cloth on the face would help. Also, I think still the best strategy is social distancing and hand washing. Without that, even if people are wearing N95 masks, which I don't think people in the public should, it's not going to help. The only two things that will definitely help are washing hands and social distancing.
So you mentioned that gloves are more or less worthless at preventing the spread of disease, because as soon as the glove touches something and then touches something else, it's spread the disease. So are there any other common misconceptions you're hearing that you would like to address?
I think one of the most common misconception is that young people don't get COVID. And that's why in some cities or in certain populations, there's young people who are going out and say, hey, I'm immune, so I'm, let me live life as is. But unfortunately, there's two parts of the story. One is that not all young people are immune. There are some young people who have COVID and unfortunately have died with COVID. again, the proportion is low, but still, you know, a young person without pre-existing conditions dying is also a big deal. And the second part to this is that you are putting the older population that you love at a very high risk by not doing social distancing, by thinking that you're immune. Because honestly, no one is absolutely immune to COVID. The only two things that we, as medical professionals, keep saying is that don't take this lightly. Again, there's no need to panic, but there is enough reason to follow the rules and follow the guidelines.
So I've been seeing a lot of articles talking about symptoms of COVID-19. And it seems that the major ones, dry cough, fever, and symptoms associated with fever. But I've also heard some situations where it causes nausea and gastrointestinal tract issues. Read another article about people having strokes from it.
So that is true. COVID-19 is presenting with a wide range of things, right? From what you mentioned, also like some skin rashes and skin and skin manifestations of this. So I think there's a lot of way the disease is presenting, and we still don't exactly know why, to be honest.
So would you say that COVID is unusual in this degree of symptoms, or have we just not figured it out yet?
COVID is definitely unusual. We have figured out some of the basics, I want to say. Most patients present with like lung symptoms. A few of them present with heart symptoms. So most of the things are, at least presentation wise, figured out. Treatment wise, there's a long way to go to figure out what works, what does not work. And for those things, I think we need proper randomized controlled trials. So one thing that I find very concerning is that everybody feels like they know how to treat this with whatever they read about. I would want people to know is that trials and science is very important when it comes to treating an illness like this. So if there are certain reports that X drug, like say chloroquine or hydroxychloroquine, works wonders, according to some media reports. However, the science is not showing that right now. Do we want it to work? Absolutely. The whole world is trying to pray for it and pitch for it. But at this point, there is no data to prove that one drug works versus the other. Also, we don't have data to prove that, say, turmeric works, or we don't have data to prove that just being in the sunlight for 12 hours a day works. Again, these are things that are touted, and there's a lot of false claims by people, individuals, who some of them claim to be doctors. And I think we all need to be very careful about what we consume in terms of content, and what do we interpret out of it. I would still make sure that everybody reads up the science behind it before adapting any strategy that somebody puts out. While we actively are working to get the data and enroll patients in trials, the public should not be taking these medications either as prevention therapy or as treatment without the guidance of a certified healthcare professional.
So you're talking about all of the things that we're still trying to learn about this disease, and that we will eventually reopen the economy. We will eventually return to some sense of normal. And I was wondering if you could talk about what that normal might look like, and how public health systems and infectious disease research may change as a result of what we've learned.
I think infectious disease research has been important and has had a lot of interest. But since penicillin was the breakthrough back in the 1950s, I want to say, people did not think that infectious disease is going to change the world, right? In some sense, like where with the HIV and epidemic in the 1980s and 1990s, again, there was some interest, and then, eventually we figured it out, and the interest sort of slowed down. The If you see, the CDC budgets were cut in the past 4-5 years, and there was not that much investment in infectious disease research, which also maybe may play a role in not having the infrastructure and things that we needed for a pandemic like this. So I think going forward, from a political or a health policy standpoint, all over the world, even WHO, all of these people are going to invest much more heavily in infectious disease research, because they can see what can happen. Not a lot of people expected that this would have such big disruption on lives of everybody throughout the globe.
So as we come out of this first wave of COVID-19 infections, what is the risk of a second surge? How likely do you think it is? What can we do to avoid it? And what might our new normal look like with that in mind?
These are all very good questions. All of us have that in mind. The honest answer is that we don't know. What we know is that there is definitely a risk of it coming back if we're not careful. So we do need to be careful from a personal standpoint and a public health standpoint. I don't think opening up stadiums or large gatherings would help, and that would definitely be something that I would worry about a lot. However, there would be the return to new normal. I think everything will adapt, right? We've adapted all our responses in all the fields, let it be finance, medicine, health supply chain, or whatever you can say. So there is definitely going to be a lot of adapting new strategies when we return to the new normal.
So you've now been on the front lines during the H1N1 crisis and now during COVID-19. And so I'm wondering, what inspires you? What gives you hope going forward?
I guess the H1N1, I was an intern trying to figure out what's the best I can do. With the COVID-19, more so than seeing patients directly in the ICUs, I feel like working on the research behind working on COVID-19 research keeps me going. I feel like I'm contributing not only for the individual patients that I see, but also sort of having a broader outreach with my work, and hoping to help people and save some lives with the research that I'm doing.
Dr. Mehta, thank you so much for taking your time to share your expertise with us today, covering everything from health disparities to telecommunication to the importance of paying attention to the science. So thank you again, and we hope we have an opportunity to speak with you again soon.
Sure. Thank you so much for having me.